My name is Wilson Ramos and I'm going to talk about crepitus and subcutaneous emphysema. Definition: subcutaneous emphysema results from any process that allows free air to enter into the subcutaneous tissue. The most common cause include pseudothorax or pneumomediastinum. In addition, it can be complication of fracture of the orbit, which permits free air to escape from the nasal sinus in the neck the thorax. Subcutaneous emphysema can follow tracheotomy, deep ulceration and the pharyngeal region, esophageal wounds, or any perforation lesion on the larynx or trachea. It is occasionally a complication of thoracentesis asthma or abdominal surgery. Rarely, air is formed in the subcutaneous tissues by gas-producing bacteria.
Hi, today's story is about the subcutaneous emphysema. When we have problem with lung overexpansion ascent, there are four major symptoms like subcutaneous emphysema and other areas like lung, heart, and even arterial circulation. The air can go in there and cause lots of problems. But today's issue is about the subcutaneous emphysema without breath hold ascent. Very recently, sorry about this, but this is my SNS and had a question like this. And it says, "Hi doc, I'm now diving on a liveaboard and just finished my third dive of the fifth day. Looks like there's only one more day left. I had some problem with Valsalva and had to force a little harder than usual to clear my ears. On board again, I feel some cracking sound or feeling under the skin of my right shoulder, neck, and upper chest. And my dive master is telling me that I might have some subcutaneous emphysema. Can air escape from the middle ear and go to shoulder and chest? I do not think I made a breath hold ascent. Would it be okay to dive now? I have my last day of 2 dives tomorrow morning and I need some advice, please." Very interesting incident. I personally didn't experience this before, and this was my answer, and it goes, "Hi, alveoli can rupture when you Valsalva too hard because the pressure inside your alveoli can go higher than the pressure alveoli membrane can resist. The tolerable pressure difference varies. The air from your middle ear cannot find its way to subcutaneous tissue for sure. No hyperbaric therapy is needed, and I recommend you to stop diving from now and for at least 4 weeks so that the damaged alveoli can heal. It would be a good idea you abstain from diving when you have any equalization problem. They can be the alveoli can be damaged even easier." This is a very rare occasion, post-dive subcutaneous emphysema without lung overexpansion injury. So it comes from pulmonary barotrauma. When you do some too strong equalization, Valsalva, that can elevate the pressure of air space of the lungs. Air escape through lung tissues, then goes to subcutaneous tissue. So again, it's very important that we don't dive when we have equalization problem. Soon I will come back with general bubbles and alveoli problem. So this was a very brief story on subcutaneous emphysema without making breath or descent. Thank you very much.
Applications in medicine. An 86-year-old woman with a history of severe emphysema presented to the emergency department with sudden onset shortness of breath. 2 weeks earlier, she had been treated for community-acquired pneumonia that was complicated by a pneumothorax on the right side, leading of the temporary insertion of a chest tube. The drain was removed before the patient was discharged. Without complication examination during the current presentation, the oxygen saturation was 82%, while the patient was breathing ambient air and breath sounds were diminished in the right hemithorax.
Hello, today we'll be talking about a very short topic, which is subcutaneous emphysema. When does it happen? It happens if someone has trauma to the chest, if someone had a burst of one of his alveoli. It can also be seen if someone had esophageal perforation. So basically any structure that has air in it, if there's a loss of integrity in it while it's in the chest, this can go out and from that structure and go through the tissues. Now, if that air reaches all the way to the skin, you will end up with something that is called subcutaneous emphysema. People describe subcutaneous emphysema as if you put your finger on the skin, you'll feel as if there are bubbles. And those bubbles will have some kind of sound as if you're touching bubble wrap. And you can feel it with your tip of the fingers. And at the same time, if the air quantity is too much, that might lead to a feeling of swelling, and it might be painful. Now, this subcutaneous emphysema is usually something that we do not treat. It's something that we discover, and it would tell us something about the patient. For example, the trauma extent, or for example, if a patient has COPD and had some air bully, and those air bully burst out. So that tells us that a patient is advanced or has severe COPD. Most of the time, we don't need to treat it, and it's something that we just can do just monitoring, unless. Imagine if you have an organ that has air in it and it burst, and that air, for some reason, entered the pericardial sac. Okay, if it enters the pericardial sac and it causes pressure on the heart, that will develop something which is very similar to cardiac tamponade. All right, and you can watch one of my other videos talking about cardiac tamponade. At the same time, if you have the lung and the lung burst out and the air got into the pleural sac, you will have something what we call a pneumothorax. And if the air goes into the mediastinum, we call it pneumomediastinum. And all of those can be conditions where surgical attention is needed. The surgeon would open the chest or would open the area and would end up with a chest tube that is placed under water seal. So let us show you an example of subcutaneous emphysema. I chose this x-ray because if I ask anybody to comment on this x-ray, everyone is gonna recognize that the lungs look really, really bad. Okay, so you can call it bilateral infiltrate, diffuse, and some people might just stop right here. The problem is a chest x-ray is not just for the lungs. You have to look at other things. So I want to note to you, if you look at this area where the skin is, you can see that there is some black streaking over here in the skin. You can also see it on the other side. And if you look under the axilla over here, you see the same thing. You see some air going here, which is black, in between the white tissue. And in this case, this patient has subcutaneous emphysema. You can see it on both the right and the left neck, and you can see it on the left chest wall. That's why when you're reading chest x-rays, you always have to have some kind of methodology. Otherwise, you'll be looking at the lungs and you'll be forgetting other things which might tell you something else. All right? And that's it. That was a very short topic. If you like this short lecture, please like, share, and subscribe to our channel. Thank you for watching.
Pros and cons. Pros. Most CAC is self-limiting and resolves spontaneously without intervention. However, massive subcutaneous emphysema that is extending beyond the torso into the neck and head should be addressed to prevent the depletion described above. Cons. In most cases, subcutaneous emphysema is self-limiting. However, it can be source of discomfort, discernment, and distress to the patient in the interim. In a minority of patients, CSE can be extensive with tension, phenomenon, leading of dysphagia, dysphonia, palpebral close, and even airway compromise requiring endotracheal intubation.
Subcutaneous emphysema occurs when air gets into tissues under the skin. This usually occurs in the skin, covering the chest wall or neck, but can also occur in other parts of the body. Subcutaneous emphysema treatment: swelling of the neck and chest pain, sore throat, neck pain, difficulty swallowing, wheezing and difficulty breathing. Subcutaneous emphysema treatment. Subcutaneous emphysema is not a curable disease. Once lung damage has occurred, it cannot be reversed. The goal of treatment is to stop further lung destruction and preserve lung function. The patient needs to know that the focus is on improving quality of life and limiting the intrusion of emphysema on daily activities. Subcutaneous emphysema tends not to be the primary cause of death, but can be a contributing factor to other organ failure. Subcutaneous emphysema is a common disease, yet every individual needs unique treatment and care. We encourage people with subcutaneous emphysema and their families to learn as much as possible about the latest medical treatment and approaches, as well as healthy lifestyle choices. For more information about subcutaneous emphysema and how to treat subcutaneous emphysema, just click on the link at description or visit www.mainmd.com. Thank you.
Issues applied in Ecuador. Our case reported the first case report of beginning postoperative subcutaneous emphysema following open abdominal gynecologic surgery, while a necrosis infection or perforated viscus is utmost concern in the postoperative patient demonstrating subcutaneous emphysema. This case represents the importance of clinical examination for each case. Our patient was clinically stable without evidence of toxicity. Conclusion: most cases of subcutaneous emphysema in pneumothorax are mild and self-limiting and do not require treatment. When CSA develop intercostal drains in situ should always be checked to make sure they are appropriately placed with all side parts in the thoracic cavity and that they neither kidney block or clamp. Thank you for your attention.